Hello everyone. So we have 65-year-old lady. She come to you due to a month of back pain. The pain is primarily in her lumbar and thoracic spine and is partially relieved with acetaminophen. Is worse with activity and has limited her ability to take even yoga classes also. Well, she take over-the-counter calcium and vitamin D supplement, and her yearly examination 4 months ago was done, and at that time the lab examination was normal, including physical examination was normal. Well, at the moment vitals are normal. Patient is thin but appears well, mucous membrane moist, no lymphadenopathy in the cervical or supraclavicular chains. Otherwise, muscle strength normal, no focal tenderness. As far as the lab report concerned, hemoglobin is reduced, and these are the normal reports. Well, if you look into the lab reports, all these reports are normal. But if you look into BUN, creatine and calcium, these are increased, glucose is in the normal range. Well, urine dipstick is negative. Urine sediment is bland except for a few granular casts. Most likely cause of the patient condition is, well, the answer is monoclonal proteins. Well, multiple myeloma is a type of plasma cell neoplasm, and patients with multiple myeloma often present with constitutional symptoms like fatigue, weight loss, bone pain, back pain. Like in our case, the patient has a month of back pain. The pain is primarily in lumbar and thoracic spine. That means our patient has presented with bony pains. Well, if we see the characteristic of multiple myeloma is characterized by proliferation of neoplastic plasma cell in the bone marrow, which I mentioned in the previous slide also. And that lead to bone marrow, bone destruction, hypercalcemia and anemia. Like in our case, the HB level is 10.2, anemia is there, hypercalcemia is there, all because of what we get in multiple myeloma. Excessive production of single immunoglobulin monoclonal protein, which is the option C, which is the correct answer in this case. Now look into classical lytic lesion. You can see plenty of lytic lesion in the bone marrow or in the bone in multiple myeloma. Well, as far as the immunoglobulins are concerned, they accumulate in high level in serum and deposit in the renal tubule, so-called lower nephron nephrosis. What is this? This is the nephron. And here are the immunoglobulins which are filtered, and they get accumulated in the renal tubule. Moreover, calcium also comes, and ultimately they block the nephron, what we call as lower nephron nephrosis, and that lead to renal failure. That's why in our case there is the renal insufficiency is there, evidenced by increased BUN, this normal range, increased creatine, this normal range. You can see both BUN and creatine are more than the normal range. Bland urine analysis, because urine dipstick typically detect albumin, it does not detect immunoglobulin, and there may be show some evidence of granular cast. Well, monoclonal protein can also damage the glomeruli, so that means they can damage the glomeruli also, so-called what we call as immunoglobulin deposit disease, leading to nephrotic syndrome. So now this was the nephron we discussed, what happened in the nephron, but there's the glomeruli. Even glomeruli can also be damaged later on, that can lead to nephrotic syndrome. Now, a classical term we use, mnemonic we use, CRAB is an internationally recognized mnemonic. What is CRAB? Stop the video, write down the answer. It's a very easy question. Well, in CRAB, in multiple myeloma, is a mnemonic. C for hypercalcemia. R for renal failure. A for anemia, and B for bone pains. So if you look into our case, bone pain is there, anemia is there, renal failure is there, hypercalcemia, all the four components of CRAB are there in our patient. Now let's look into other options. Vitamin D intoxication. It occurs only at an exceedingly high dose and can cause hypercalcemia. It may be associated with vomiting, confusion, polyuria, and polydipsia. Anemia, renal failure are not seen in this case. So this is not the answer to our question. But I have one more question for you. Stop the video, write down the answer. Why polyuria occurs in vitamin D intoxication? Stop the video. Well, the answer of this question is, in this case, hypercalcemia occurs because of vitamin D intoxication. So now that lead to, now we have ADH, which act on the collecting tubule, and it only absorbs water. It does not absorb sodium and potassium, nothing to do with sodium potassium. So when hypercalcemia occur, that this ADH is not able to act on the tubule, and that lead to polyuria, and this is known as nephrogenic diabetes insipidus. So that's why polyuria occurs in these cases, in case of hypercalcemia. Well, option B is incorrect, diabetes mellitus, because diabetes nephropathy occurs after many years and it tends to have albuminuria, but in our case, dipstick test is negative, so there is no albuminuria. Moreover, 4 months ago, the blood sugar was normal, so it's very, very unlikely to have diabetic nephropathy. Okay. But I have a question for you. Okay, stop the video, write down the answer in your copy. A diabetic patient has normal BUN and normal serum creatinine. Is not taking ACI but has hyperkalemia. What is the most likely cause? Stop the video. Well, the answer is renal tubular acidosis type 4. Diabetes is the most common cause of RTA type 4. In type 4 RTA, hyperkalemia occurs without any renal dysfunction. Option D, primary hyperparathyroid. This leads to hypercalcemia. Yes, everybody knows. It's a simple thing to say. But they are usually asymptomatic or diagnosed after developing calcium nephrolithiasis, which is not there in our case. Patients who have hypercalcemia associated with bone pain and anemia are more likely to be of a case of multiple myeloma, because anemia is not a feature of hyperparathyroid. SLE causes glomerular injury resulting in proteinuria, hematuria, and often with increased creatinine. But in our case, there is no hematuria and there is no albuminuria, to be more precise. Moreover, bland urine analysis making SLE is a very unlikely, because in this we definitely get hematuria. But again, I have a question for you. Stop the video, write down the answer. What are the classes of nephropathy in SLE? Write down the answer in your copy. Well, we classify into 6 classes. Class 1, minimal mesangial. Class 2, mesangial proliferation. These two are related to mesangium. Focal nephritis and diffuse nephritis. These are related to nephritis. In this category, we get wire loop appearance. Nephritis means number of nephron involvement. If less than 50, we call as focal, 50%. More than 50% involvement of glomeruli or nephron, we call as diffuse or focal, depending on what percentage of nephrons are involved. Finally, class 5 is membranous and sclerotic nephritis are this is how we classify. And remember, chronic renal failure is one of the most common cause of death in patients of SLE. Now let me show you some lovely picture of so-called wire loop appearance, which is nothing but thickened capillary loop of, so you can see capillary loop are markedly what we call as wire loop appearance. Lovely picture is there for a better understanding of subject. Golden line to remember, multiple myeloma is a plasma cell neoplasm characterized by excess production of monoclonal protein that may accumulate in the kidneys and may cause renal insufficiency. 50% of the patients with multiple myeloma have renal insufficiency at the time of diagnosis. Thank you very much.